Today is July 4th, 2024. I plan on taking my next practice exam for step 2 on July 6th on Saturday. And based on how I do on that exam, that practice exam, I will take step 2 on July 19 or 20. So this is my second video tracking my progress. And I'm already glad that I did this because it's been keeping me accountable. Yesterday, I mentioned that I wake up around 12 or 1 and I do 2 blocks of UWORLD until midnight. And after I made that video, I realized just how ridiculous that sounds, to go 12 hours. Just two blocks of UWORLD in 12 hours is absolute nonsense. And what it really came down to was, I was procrastinating instead of focusing. I was doing other things like, browsing YouTube or I don't know, like looking stuff up on the internet, like news and stuff. I mean, I wasn't focusing. So this is good because it keeps me accountable. So the plan for today is I'm going to do 2 timed blocks of UWORLD like I've been doing, but I'm also going to do 1 timed block of UWORLD on 1 untimed block of UWORLD on tutor mode. I'm going to do that block with you guys, so I can kind of talk through my logic out loud, and we'll see how that goes. So let me share my screen here. So I'm going to do a block of cardiology because on the very first practice test that I took way back in March, my weakest section was cardiology. And I'm going to do only incorrects. And so back in March, when I realized my weakest section was cardiology, I basically did almost all of the cardiology questions in a span of 1 week. So it's been a while since I've done these questions. And, I made Anki cards on all of them because I got them all wrong, but, we'll see how much that helped me remember things. So without further ado, let's get started. Okay, 23-year-old preemie gravida at 29 weeks gestation comes to the ED with sudden onset severe shortness of breath. She woke up today with a fluttering sensation in her chest, which progressed to dyspnea, dry cough, and an inability to lie flat. Recently, she has had some exercise intolerance and tiredness. She attributes this to pregnancy. Her medical history is significant for recurrent sore throat requiring tonsillectomy as a child. Lifetime non-smoker, does not use alcohol, sedentary. She's an immigrant. Blood pressure is kind of on the lower side. Pulse is tachycardic. She appears uncomfortable. EKG shows AFib with rapid ventricular response. Which of the following is the most likely diagnosis? Okay, so this, my understanding is that pregnancy worsens mitral stenosis, and then mitral stenosis, if it gets bad enough, it can cause atrial fibrillation. The other things, aortic insufficiency, I don't see anything about like a murmur that would suggest that. Concerted pericarditis, I don't think so. HCM, myocardial infarction, cardiomyopathy. So I think it's mitral stenosis. Let's see. All right, good. We're off to a good start here. And let's look at the explanation. And if I get the answer correct, I just read the educational objective because, we want to be efficient with time here. All right, so rheumatic mitral stenosis. Yeah, so rheumatic. So there was all this stuff in here about like how she's an immigrant, how she used to be sick as a kid. I feel like they always do that when there's something rheumatic going on. So that definitely rang a bell in my head, but I didn't see rheumatic fever down there. But I guess mitral stenosis is kind of hinting at that. Yeah, it can cause a bunch of changes during pregnancy, and the development of new AFib can further increase. So actually, it's the opposite of what I said. Basically, what happened is the patient had mitral stenosis and then got AFib on top of that, which made the mitral stenosis worse. And that's why she had apparently pulmonary congestion and pulmonary edema. And that would explain the dyspnea, dry cough, and inability to lie flat. Okay, good. Next question. 30-year-old man comes to the office due to progressive exertional dyspnea and fatigue for 6 months. No orthopnea or PND. Medical history significant for tetralogy of Fallot with repair performed at age 3. Blah, 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 blah. Vital signs are normal. BMI is normal. Cardiac exam reveals a normal apical pulse. Prominent parasternal impulse at the left sternal border. S2 is single. I think that means aortic stenosis. Let's keep going. Grade 2 out of 6, decrescendo diastolic murmur that increases with inspiration is heard at the left sternal border in the third intercostal space. Remainder of the exam is unremarkable. Which of the following? Okay. So diastolic and systolic murmurs, right? So something that I always keep in mind is this mnemonic is called Mr. Ass. So Mr. mitral regurgitation, Ass, AS, those are both systolic. So rule out mitral regurgitation, rule out aortic stenosis already. The location left sternal border down here. Okay, so diastolic at the left sternal border is either aortic regurgitation or pulmonic regurgitation. This single S2 here, it's a buzzword for something. I don't remember. So I'm stuck right now between aortic regurgitation and pulmonic regurgitation. It's not ASD. That defect was repaired. I don't think it's myxoma. Could it be tricuspid regurgitation? Could be that too. No, tricuspid would be systolic. Okay, so I'm between these two right now. I don't know which one to choose. Dyspnea, fatigue. Pulmonic regurgitation would have more like lung sounds and stuff, which they don't really talk about here. So, anyways, I'm gonna go with aortic regurgitation. Let's see what we get. Fuck, it's pulmonic regurgitation. Okay, so fuck. All right, let's see. And I'm gonna make Anki cards about this after I finish the video to save you guys. I don't want to do that on video because I want to be respectful of the time of whoever's watching as well. So it wasn't aortic regurgitation because it decreases with inspiration, the murmur. And I guess this isn't a complication of TOF repair, but pulmonic regurgitation, common complication of TOF repair. Yeah, okay. Progressive exertional dyspnea and a decrescendo diastolic murmur at the left sternal border. So yeah, so that's just something to remember, I guess. That this decrescendo diastolic murmur at the left sternal border that increases with the inspiration is pulmonic regurgitation. Okay. And you can see that here as well. That's a left midsternal border. So curious if that S1 sound, the single S2 sound means anything. Let's see what they say. So they don't say anything about the single S2, but the this thing they talked about, the parasternal impulse, that's because of right ventricular dilation. Okay. Next question. 76-year-old man is admitted to the coronary care unit after an episode of substernal chest pain. Other medical problems include hypertension, hyperlipidemia, and diabetes. History of diverticular bleed 2 years ago. After initial workup, cardiac catheterization is performed and shows 70% left main coronary artery stenosis and 90% descending stenosis, 80% right coronary artery stenosis. Antiplatelet agents are stopped. Patient is continued on heparin drip in preparation for coronary artery bypass surgery. 5 hours after the catheterization, his blood pressure drops. Look, it's Brady, it's hypotensive and tachycardic. Complains of some generalized weakness and back pain. Diaphoretic and clammy. Flat neck veins, so something hypovolemic is what I'm thinking here. Heart sounds normal. Chest is cleared auscultation. Right groin arterial puncture site is mildly tender. Receives 1,000 milliliters of normal saline with symptomatic improvement. Okay. Blood pressure is 96/60, and okay, so blood pressure gets better. Repeat EKG is unchanged from the original EKG, which I don't know what the original EKG was, but okay. Which of the following is the most appropriate next step in managing this patient? Okay, so he had some sort of a hypovolemic shock after this stenting, um, after catheterization. Okay, arterial puncture site is tender for some reason. So what do we want to do next? CT scan. I think that makes sense because we want to see if he's bleeding, right? CT scan of the chest, NG tube, TTE, urgent bypass surgery. Okay, urgent bypass would suggest that I don't know. You would want this if he's having an acute MI, which the EKG doesn't show. TTE, I don't see anything about like an acute like heart problem. So NG tube, we can do that later. CT scan of the chest or CT scan of the abdomen and pelvis. Well, the catheter went in through the groin, so I'm gonna go with that. Maybe something happened there. I'm pretty sure I'm gonna get this wrong, but let's see what happens. Okay, good, 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 good. Okay, retroperitoneal hematoma. Um, Local vascular complication of cardiac catheterization often presents with sudden hemodynamic instability and ipsilateral flank or back pain. Diagnosis is confirmed with a CT scan of abdomen and pelvis or abdominal ultrasonography. Treatment is usually supportive. So yeah, so it's a retroperitoneal hematoma. It's a complication of that catheter, and then you do a CT scan of the abdomen and pelvis to find that. All right, good, good. Let's keep going. 46-year-old man comes to the physician due to exertional dyspnea and dry cough. Has occasional episodes of suffocating nighttime cough that is relieved only by sitting up. Medical history is significant for MI 6 months ago and hypercholesterolemia. Meds include metoprolol, aspirin, statin. Um, Drinks alcohol on social occasions, but does not use tobacco or illicit drugs. Father died of a stroke, and his mother has type 2 diabetes. Blood pressure is hypertensive. Pulse is bradycardic. Exam shows basilar crackles. Apex is palpated in the left sixth intercostal space. Pitting leg edema. All right. And then what is most likely to be associated with this patient's condition? Okay, what is the condition? So he's got dyspnea, he's got dry cough, nighttime cough, MI 6 months ago, crackles, apex. So he's got basically heart failure on both sides because he's got the edema, because it's systemic backflow, and he's got the crackles, pulmonic backflow. Apex is deviated, so maybe some kind of like enlarged heart for some reason. All right, let's look at the answers here. It says, which is most likely to be associated with this constriction of the renal afferent arterioles? Decreased plasmacolonic pressure, decreased renal venous pressure, dilation of the renal afferent arterioles, high sodium delivery to the distal tubule, increased chloride delivery to the macula densa. All right. So immediate reaction is I have no fucking idea. But he's in some kind of a heart failure, and that's going to mess up the kidneys somehow too. That's what I'm thinking. Constricting the renal afferent arterioles renal efferent arterioles will actually increase GFR. It'll make the kidneys better. Decrease plasma colloid. I don't know what this has to do with that. Decrease renal venous pressure. I mean, the blood pressure is higher, so I'd imagine the venous pressure is supposed to be higher too, right? Dilation of the afferent arterioles. Why? I don't know why. Um, High sodium delivery, increased chloride delivery. Fuck. So I'm not sure. Let's choose an answer because you don't have all day when you take step two, right? So I feel like it's A or D. It's either A or D. I'm gonna go with D. Fuck. Something makes me think it might be C as well. It's A. Okay. So this is that, what's it called? That shit. Um, Cardiorenal syndrome. Okay. Yeah. So his presentation was heart failure. Okay. Cardiac output is reduced. Um, Triggers the renin-angiotensin-aldosterone system. Stimulates vasoconstriction and sodium retention to maintain organ and tissue perfusion. Specifically, angiotensin 2 causes vasoconstriction of both the afferent and efferent arterioles. But more prominently of the efferent arterioles to maintain. Oh, so that's the whole point. It's a compensatory mechanism to increase GFR. So I got the GFR thing right at least. Ultimately, these mechanisms are maladaptive as vasoconstriction increases afterload and sodium retention increases preload. Yeah, so that makes the heart failure worse, right? Um, so it's a vicious cycle. Okay. That makes sense to me. So I don't know why I got this question wrong the second time, but and that is what it is. So, okay, next question. 68-year-old woman comes to the office for follow-up after a recent ED visit 2 weeks ago. She experienced palpitations and mild dizziness. At that point, she was diagnosed with AFib with RVR, which resolved spontaneously in 2 hours, and then she had no symptoms after that. Okay, she has a history of hypertension with valsartan and hydrochlorothiazide. Um, does not smoke, does not drink alcohol. Exercise tolerance is good. BP is good. Pulse is good. Exam is normal. TSH, I believe, is normal. Let's just take a quick look at the lab values to make sure. Good, it's normal. Creatinine, 1.1. I think that's a little bit above normal, but it's not concerning. Glucose is fine. Echo, preserved LVF. So everything's normal. What's the next step in management of this patient who had an episode of AFib with RVR in the past and who has hypertension? Ambulatory heart monitoring, I don't know about that. Amiodarone, apixaban. So amiodarone is for what? Rhythm control or rate control? I don't remember. I think that's rhythm control. Apixaban is shit. It's a anticoagulant. Aspirin is also an anticoagulant. Carotid, ultrasound. So she's doing fine. I think the treatment for AFib is like a beta blocker and a non-dihydropyridine, like a metoprolol and a diltiazem or something. Those aren't even options here. Um, I was hoping they would be. I guess if she was still on AFib, we would maybe want to anticoagulate her because AFib increases the chance of that. But right now she's doing fine. Echo is normal. So I'm going to say clinical follow-up only. I feel like this is what I probably said the last time because, but so I'm probably going to get this wrong, but let's see what happens. Fuck. Okay, so apixaban. Oh, and it's that Chad's Vask shit. Man, this is so frustrating, because I learned about Chad's Vask like 2 years ago. This is like basic med school shit. I still fucking get it wrong. So this is step two in a nutshell. It's so fucking frustrating. I feel like an idiot, every single fucking day. So I know exactly why, because so Note to self. I'm sure I'm going to forget this note, but note to self. If somebody has AFib, you should think about their CHA2DS2-VASc score. So hypertension, that rings a bell. That's 1 point. Let's see what else she had. She's 68 years old, so that's a second point there. She's a female, that's a third point there. Um, so that's 3. Okay, so total score is what? 3. Stroke risk is high. You have to start an anticoagulant. Okay, so I need to keep that in mind. I fucking got it wrong again. So, all right, excuse the language. Excuse the language. Next question. 48-year-old woman who comes to the office for cholecystectomy. She's had some postprandial upper abdominal pain and nausea, gallstones, cholelithiasis, right? After discussion, blah, 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 they said she needs a cholecystectomy. She's obese. She has hypertension. So anesthesia is given with the endotracheal intubation. Immediately after needles placed in the intraperitoneal space and CO2 gas insufflation is performed. And then immediately after that, she gets bradycardic and gets transient AV block. So what happened? Peritoneal stretching causes some kind of a parasympathetic reaction. So let's see what happens. I know I got this right. There we go. There we go. Finally, the Anki cards I made 4 months ago are helping me out here. Laparoscopic intra-abdominal surgery, blah, 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 blah. So it stretches the receptors on the peritoneum, triggering a vagal tone. Okay, good. Next question. 53-year-old man comes to the ED due to squeezing chest pain that started 2 hours ago. All right, sounds like an MI. Keep going. Shortness of breath when lying down. That's orthopnea. Never had pain like this before. Okay. No significant medical history, no medications. Routine health maintenance visit 2 weeks ago was normal. BP is normal. Pulse is a bit tachycardic. Auscultation reveals grade 3 out of 6 systolic murmur at the apex and bibasilar crackles, ST elevations, and 2-3 and AVF. Okay, this is a right ventricular MI. What's going to be abnormal here? Left atrial compliance, left atrial size, left ventricular compliance. See, so I know what this is, and then the fucking question is like asking about all this other shit that I just don't know. So, all right, so let's think about it. The right side of the heart isn't working. Okay. What does that have to do with left atrial compliance? Nothing. Left atrial size, nothing. Left ventricular compliance, nothing. Left ventricular end diastolic pressure, would that be increased? Systolic aortic flow. I feel like if this is increased, if D is increased, then E would also have to be increased, right? But also it makes sense that D would be increased because the right ventricle is weak, so it's not pumping as much blood into the pulmonary arteries. So actually, this would have to be decreased, the left ventricular end diastolic pressure. Why would the left atrial size be increased? So I really don't fucking know here. Um, I'm gonna say D because it rings a bell. Let's see what happens. Yeah, so yeah. I've been making Anki cards, and so the D, I just remember this LVED, so but let's see why. So he's got the right ventricular MI, so I got that part right. Complicated by acute mitral regurg. Yeah, so what I did there is I read about this murmur and then I just stopped thinking about it. I just moved on. Okay, so this murmur is classic mitral regurgitation. So that much I knew. That much I should have known. And an MR causes papillary muscle displacement as a result of LV hypokinesis, blah, 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 blah. And then it increases LA pressure because you get backflow of blood into the left atrium from the left ventricle. This pressurized left atrium blood volume rapidly fills the LV during diastole, increasing LV and diastolic pressure. Increased LA pressure is also transmitted backward through the pulmonary veins to cause pulmonary edema and acute decompensated heart failure. This guy does not have any signs of heart failure, but I guess he should have. Classically associated with, yeah. So the murmur is MR. Okay. All right. Just reading about MR here. Okay. Next question. EKG. Let's take a look at that. All right. This is AFib, right? The RR intervals are abnormal, and then you see all this squiggly crap down here, which I think is a bunch of P waves. Okay. The which of the following is the most appropriate next step? Adenosine? No, that's for SVT. Cardioversion? Maybe. Sinus massage? I know. Diltiazem? Maybe. Lidocaine? No. So it's either B or D. Let's read it. History of hypertension, diabetes. He has generalized malaise and palpitations for 2 weeks. EKG shows mild left atrial dilation and left ventricular hypertrophy. Meds include lisinopril and hydrochlorothiazide. BP is wow, so this is pretty high. His BP is high. So my understanding is, diltiazem if he was stable, but because he's symptomatic, he has this high BP. Let's go with cardioversion. Let's see what happens. No, it's diltiazem. So fuck. Okay, it's frustrating. It's frustrating stuff. Okay. Management of adult tachycardia with a pulse. So it's AFib, that much we know. Um, so if he was hemodynamically unstable, which would have been severe hypotension, not hypertension, confusion, or ischemic chest pain, in that case, we would have done cardioversion. But because this guy's hemodynamically stable, then we do the rate control. So then we do either the beta blocker or the diltiazem. So we did diltiazem here. And then says some other stuff here for long-term rate control. Second agent can be added later, like metoprolol. Don't use digoxin, and amiodarone has some properties too. Rhythm control strategy is pursued in some patients using cardioversion and other agents like amiodarone, etc. And then, of course, like we saw a few questions before, we always have to be aware of this thromboembolic risk. Okay. I don't mind getting this wrong. I just want to make sure I remember it now. So I'm gonna, after this video, after I'm done with this block, I'm gonna go back and revise all of my Alki cards. Okay, next question. Let's keep going. And I'm already behind on time. I have to do like 1 minute and 30 seconds per question. So I should not be at 15 minutes at this point, but I'm talking, so of course I'm a bit slower than I should be. Okay, next question. Newborn girl has a heart disease screening. Okay, normal birth, normal duration of labor, uncomplicated labor, stayed with mom, breastfeeding, voided in stool twice. Okay, so far so good. Pulse ox, 99%. Okay, so we have some discrepancy here. Right hand is 99% saturation, right foot is 91% saturation. While peering, no cyanosis seen. Okay, pulses are fine. Okay, so immediately this discrepancy in pulses makes me think aortic coarctation. Well, let's see what the options are. Hypoplasia of the aortic arch, maybe, so that I think that's kind of what aortic coarctation is, right? Left to right intracardiac shunt, that's VSD. I think that would cause systemic hypoxemia. not not just, you know, differences between levels of the body. Malformation of the pulmonary veins, I don't know what that means. Persistence of fetal circulation, again, that's basically what B is referring to. I mean, that's ASD or VSD. I don't think so. RVOT, I don't think so. So I think it's A. The fact that I got this question wrong means that's probably not A. Let's see what happens. Because I don't imagine why me in the past would have chosen a different answer, but yeah. Oh, it's this persistent pulmonary hypertension of the new. Okay, so what the hell is this? Low postductal saturation relative to her preductal saturation is consistent with the right to left shunt across the PDA. Okay, let me Google what the PDA is really quick. Because I have trouble keeping all these shunts together. I mean, I know what a VSD is, I know what an ASD is. What is a PDA? Yeah, it's between the pulmonary artery and the aorta. Okay, and we want to keep this open in some diseases. I forgot why. I forget which ones, but anyways. Okay, so basically, basically blood, like non-oxygenated blood from the right side, is getting shunted into the aorta from this PDA. Um, and then because the pulses are strong, that means it's persistent pulmonary hypertension of the newborn. Okay. So at birth, you have high PVR, right? Because blood should not be going into the lungs. Um, and then with oxygenation and stuff, that PVR will decrease and the blood should go into the lungs. But in this disease, fetal circulation is persistent, meaning that the PVR remains elevated. And yeah, so blood does not go into, not enough blood goes into the lungs. And so you have this deoxygenated blood going into the pulmonary artery of the aorta. And I guess that means that you have lower postductal saturation, right? So yeah, let's look at the aorta structure here. Yeah, so you see these two vessels here, which I guess these are the ones that goes to the arm and the head and whatnot. Those are before the duct. So the saturation there is fine. But then you have this PDA putting in unoxygenated blood before this vessel and the rest of the aorta. And so I guess that's why the bottom, the lower part of the body is not as well oxygenated. So, that makes sense. That makes a lot of sense. I wish I had thought about it like that before. I just made an Anki card, basically. So my Anki card did not help with this, so I gotta revise that. Okay, risk factors for this are lung hypoplasia, infection, meconium aspiration. Okay, good, 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 good. So let's keep this in mind and let's keep going. Keep grinding. Question 10. 23-year-old man after an MVC found unresponsive at the scene and intubated by paramedics, administered some saline. He was a driver. Upon arrival, he's hypotensive and tachycardic. So immediately hypotension, tachycardia, that immediately blood loss. That's the trigger. Patient response to strong vocal and tactile stimulation, good. Pupils are equal and reactive to the light. Neck veins are distended. Now that doesn't make sense if he's losing blood. So what's going on here? Keep going. Multiple bruises involving the anterior chest and upper abdomen. Chest X-ray reveals a small left-sided pleural effusion and normal cardiac contours. Which of the following is the most likely diagnosis? Aortic rupture, bronchial rupture, cardiac tamponade, esophageal rupture, lung contusion. I feel like it's got to be aortic rupture. But he would be dead if he had an aortic rupture. Bronchial rupture, there would be more about like lung symptoms. Tamponade, could be tamponade. Could it be tamponade? Tamponade is Beck's triad. It's hypotension, muffled heart sounds, distended neck veins. We have the distended neck veins. We have the hypotension. We don't see any muffled heart sounds, but it doesn't say anything about the heart sounds. So right now I'm thinking tamponade. Esophageal rupture, again, we would have more pulmonary symptoms, same with contusion. So tamponade is my answer. Let's go. Let's go. And then, yeah, we got Beck's triad here. At least two parts of Beck's triad. And it's an acute tamponade, or is it a subacute? It's acute. So that's why a chest x-ray looks normal. So that's probably what threw me off the first time. This pleural effusion probably threw me off the first time. And that's probably what made me, I guess the last time I probably must have chosen like lung contusion or something because of that. But I guess when it's an acute cardiac tamponade, it causes that pleural effusion, right? Unlike subacute tamponade, the cardiac silhouette can be normal, and small amount of pericardial fluid can dramatically increase pressure. What does it say about the pleural effusion? Let's see. Okay, it doesn't say anything with the pleural effusion. So maybe the pleural effusion is from something else, right? Um, but regardless, in lung contusion, the pleural effusion will be on the left side. Oh, it is on the left side. But the neck veins will be flat. Okay, so if it wasn't lung contusion, the neck veins would be flat. Okay. And that's another thing, I need to do a better job of actually like reading these, because when I'm not talking through it, I feel like that's something that probably must have happened last time. That I probably must have just skimmed this over, probably skimmed over the fact that his neck veins are distended and then chose lung contusion. So read the whole fucking question. Um, okay, next question. 56 male comes to the ED, sudden onset epigastric pain and dizziness that began 2 hours ago. Also has nausea, history of hypertension, hyperlipidemia, and GERD. He drinks, he smokes, BP is hypotensive, pulse is bradycardic, he's diaphoretic. And then EKG shows T wave inversion in 2-3 and ABF. So what is the next step? All right, if it was a right ventricular MI, you would see ST elevations, not T wave inversions in 2-3 and ABF. So some shit's going on with the right ventricle. T wave inversion, what causes that? I don't really remember. I'm thinking some kind of electrolyte shit. Um, but the sudden onset of epigastric pain and dizziness and diaphoretic, this all screams heart attack. Um, CTA, maybe. Could this be like an aortic? What do you call that? Aortic dissection? It could be with the hypotension. That makes sense, right? He's losing some blood. Furosemide, why would we give that? Doesn't make sense. Right-sided precordial EKG. We just did an EKG. Natro, for what? I mean, I guess that would relieve pain, but if something's going on with the right ventricle, you don't want to give natro. Upright X-ray. So it's either CTA or X-ray. If it's aortic dissection, we want to do a CTA. Fucking A, dude. Okay. So it is in right ventricular myocardial infarction. And those T wave inversions are ischemic changes in 2-3 and AVF. And the epigastric pain. So hypotension is a feature of RVMI. Yeah, you should avoid nitrates if you have RVMI. That part I got right. Whenever inferior wall MI is suspected based on ischemic changes in the inferior leads, right ventricular involvement should be evaluated using a right-sided EKG, which I guess is like the opposite type of lead placement, right? So I that's like that smoke over fire stuff, whatever. Okay, it's the opposite of that. Um, okay, so hypotension, bradycardia, epigastric pain, all of that should have rung bells for right ventricular MI, and then the EKG as well, and then you have to do a right-sided EKG if that's what you're thinking about. This is not aortic dissection. I mean so the reason they even suggested CTA is because they might have thought that I would have thought it would be pulmonary embolism, but it's not. I mean, yeah. So next question. Keep grinding. Keep going. 32-year-old man comes to the office due to occasional palpitations. Medical history is not remarkable. Considers himself healthy. Maternal uncle died suddenly at age 40. Cousin had heart surgery at a young age. Examiner asks the patient to sit upright, lean forward, and hold his breath in full expiration as the stethoscope diaphragm is placed to the left sternal border and firm pressure is applied. Okay, so he's like Valsalva-ing, and then when he does that, there's a decrescendo early diastolic murmur. Where at the left sternal border? Okay, diastolic murmurs at the left sternal border. What could that be? It could be mitral stenosis or tricuspid stenosis. So which of the following is likely diagnosis? ASD, bicuspid aortic valve, hypertrophic cardiomyopathy, endocarditis, rheumatic heart disease. The fact that the murmur gets worse with this Valsalva stuff makes me think hypertrophic cardiomyopathy. The fact that his uncle died at a young age makes me think hypertrophic cardiomyopathy. So this clinical picture, to me, pointing towards hypertrophic cardiomyopathy, I don't see signs of anything else. So let's see what happens. Let's see what happens. I'm gonna choose C. Hopefully I get it right, but we don't know. Let's see. Of course I got it wrong. Of course I fucking got it wrong. So let's read the explanation. This is frustrating. This is so frustrating, man. Okay. All right. So why isn't it hypertrophic cardiomyopathy? Let's look at that first. So yes, the family history makes sense. HCM would be a systolic murmur, not a fucking diastolic murmur. Right? So let's see, left midsternal border. It's a systolic murmur, left mid. So I should have known that. So should have fucking known that. And then yeah, I was right about the Valsalva thing too, but it's a systolic murmur. Okay, now this bicuspid aortic valve business, aortic regurg. So bicuspid aortic valve is another way of saying aortic regurgitation. And aortic regurgitation is a diastolic murmur on that left side. Yeah, that's why I didn't choose it, because it's normally bicuspid aortic valve is associated with AS, but I guess in developed countries apparently it causes aortic regurgitation. So learning points: decrescendo diastolic murmur, left sternal border. That's aortic regurg. Family history suggests bicuspid aortic valve. All right, next question. All right, next question. 55-year-old man brought to the ED after falling from a 20-foot height. Patient was leaning over a second-story roof to hang Christmas lights when he lost his footing and fell forward. Although he partially braced his fall with outstretched arms and legs, his body hit the pavement with full force. Now he has severe chest and back pain. Blood pressure is high in the left. Pulse is tachycardic. Respirations are a bit high. On PE, on physical exam, he's alert. Voice is hoarse. That makes me think something happened with there's like a nerve that's around that area. Pupils are symmetric, blah, 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 tracheus midline, bruising over the sternum. Breath sounds are symmetric. Good. Abdomen and blah, blah, blah is fine. Superficial abrasions on the palms and knees, okay, don't care. Lower extremities are cool to touch. So something happened with the aorta, right? Just like that, just like a few questions ago with that pulmonary hypertension of newborn, something's going on with the aorta. Okay, so what do we do to confirm the diagnosis? Chest tube placement? No. CTA? Maybe. Esophagography? Uh, no. Bronch? No. Pericardiocentesis? No. Or maybe B. I mean, maybe F. Echocardiography. So do we want to do echo or do we want to do a CTA? A CTA is going to take longer than an echo, right? And so if he was hemodynamically unstable, we would want to do an echo first and then do a CTA later. Okay, but is he hemodynamically unstable? I mean, he's not hypotensive. His doesn't say anything about his mental status being weird, but then these lower extremities being cool to touch and the femoral pulse is being diminished. Shit, that makes me think we should do an echo to see what happened there. But then also, okay, if the femoral pulses are diminished, would we want to do a CTA to look at the rest of the body, not just the heart? Maybe, but let's go with F. So I'm thinking B or F. Let's go with F. Of course it's fucking B. Of course it's B. Okay. So aortic injury. That part I had right. Um, because he survived the fall, it's probably not a complete rupture, obviously. Okay, fine. And yeah, that's the hoarse voice and stuff is because of that nerve which runs in that area, that left recurrent laryngeal nerve. It does this weird stuff. I remember something from step one. So CTA is the best to diagnose this. TEE can also evaluate this area, but TTE is not that good. Okay. Question 14. 22-year-old woman is brought to the ED after she passed out on the field while playing soccer. Episode lasted only 2 minutes and was not associated with any post-event confusion, sleepiness, or weakness. Describes herself as healthy, but on detailed review, systems admits to occasional lightheadedness and vague chest discomfort with playing active sports. Grandfather died suddenly at age 40 from a heart attack. Blood pressure is 128 over 74, pulse is 67. Exam S4 is heard at the cardiac apex. 3 out of 6, mid-systolic murmur is best heard to the left lower sternal border. Does not radiate to the base of the heart or to the neck. What will he benefit from? So let's go back, look at this question again. She had syncope, lightheadedness, and vague discomfort while playing sports. She has an S4 heart sound. What is this? Mid-systolic murmur, left sternal border. Does not radiate. Makes me think aortic stenosis. This systolic murmur makes me think aortic stenosis. But then the question is, what do we do about it? Amiodarone, anticoagulation, pacemaker, beta blocker, valve replacement. I have no fucking idea. I have no idea. We don't want to do valve replacement because he's 22 years old, right? Beta blocker, why would we do that? Pacemaker, why would we do that? She doesn't have any she doesn't have AFib. Anticoagulation, amiodarone. So I have no fucking idea. I'm gonna go with metoprolol, but I really don't fucking know. Well, I got it right. Finally, I guessed something and I got it right. So she's got hypertrophic cardiomyopathy. Yeah, normally I would think of hypertrophic cardiomyopathy with males, but I guess, females can get it too. Fatigue, dyspnea, chest pain, palpitations, and presyncope. Yeah, the vague chest discomfort was supposed to mean palpitation. And then you treat that with a beta blocker and a non-dihydropyridine, just like you treat um, AFib. Good, good, good. Keep going. 65 male comes to the ED due to substernal chest pain, severe shortness of breath, and diaphoresis that suddenly began 40 minutes ago. Pain gradiates to the left arm, does not remit with sublingual nitroglycerin. So this is some kind of an atypical angina, but it started 40 minutes ago. So it's acute. So it's concerning. He's vomited twice since the pain started. EKG shows ST elevations in the anterior leads. So maybe a left ventricular MI. O2 sat is 90% on 4 liters. Cannula S3 is heard. S3 makes me think there's some kind of a heart failure. Basilar crackles, again, makes me think heart failure. And they give him aspirin, clopidogrel, and atorvastatin and anticoagulation. And then what do you give next? Okay, so this is basically acute heart failure, right? I was thinking maybe it's an MI. Fuck, it could be an MI because of that EKG. If it's an MI, you would also want to give a beta blocker and an ACE inhibitor, right? Do we see beta blocker or ACE? We see metoprolol here. But I feel like, I'll be honest with you guys, I feel like because I did this question before, I think the answer was spironolactone. That's what I think it was. Because some of these things are pointing towards acute heart failure more than MI, like the lung sounds, the S3, or it could be cardiogenic shock as well. Fuck, it could be a lot of things. But this acuteness of the symptoms makes me think MI, unless it's an acute exacerbation of heart failure. So I'm going to go with F because I feel like that's the answer. Let's see. Of course, the answer is C, something I didn't even consider. So it is MI. It is MI. And then because of the pulmonary edema, he's got these bibasilar crackles. You should give furosemide in addition to this other cocktail they gave with the aspirin, the clopidogrel, the atorvastatin, the anticoagulation. Why not the beta blocker? Beta blockers improve mortality in acute MI, but they're contraindicated in decompensated heart failure. And what happened here is she had an MI on the left side, and that caused acute heart failure. And because it's on the left side, the blood backed up to the lungs. And so because it's an MI complicated by heart failure, that's why you should not give beta blockers because beta blockers can worsen heart failure. So don't give beta blockers. Give furosemide, and then spironolactone is not indicated in the acute setting. So this is frustrating, isn't it? Let's eat some Chips Ahoy. Keep going. So I told you guys yesterday, it takes me I'll wake up at 12 or 1, and then I do 2 blocks of UWORLD, and it takes me, that basically lasts the whole day, right? I'm done around midnight, and then I do Anki. And I was thinking that doesn't make sense, but right now it makes sense because right now it's 1:44 p.m. And then after I'm done with this block, I have to make Anki cards based on this block. And then after this, I have to do 2 blocks of untimed. I mean, 2 blocks timed non-tutor, and then make Anki cards based on those incorrects. So it makes sense why this lasts so long. Next question. 72-year-old man, recurrent chest pain, admitted for anginal chest pain and underwent coronary artery bypass with a saphenous vein graft 10 days ago. Recovered well after the operation and discharge was planned, but since yesterday, he has had worsening retrosternal chest pain and dyspnea. Current meds are aspirin, statin, metoprolol. Morphine is needed. He has fever, has tachycardia, serosanguineous drainage from the chest wound from that bypass he had for the saphenous vein graft. With his tender to palpation, EKG shows sinus tachycardia, but otherwise it's normal. Labs show mild anemia, leukocytosis, thrombocytosis, mildly elevated creatinine, normal troponin. Chest X-ray shows mediastinal air with no lung infiltrates, pleural effusion, or a pneumothorax. I think the mediastinal air is abnormal. I don't think you should see that on chest X-ray. I might be wrong. Echo shows a small amount of pericardial fluid. What's the next step? Small amount of pericardial fluid immediately rings bells. Is it pericarditis? Is it tamponade? Well, the blood pressure is normal. I don't see anything about JVD, so I don't think it's pericarditis. I think that's just some kind of acute inflammation. Mediastinal air, fever, makes me think it's some kind of mediastinitis, right? What do we do for that? Antibiotics and observation, antibiotics and debridement, NSAIDs and colchicine, NSAIDs and pericardiocentesis, urgent angiography. So we're going to give antibiotics. Do we want to do observation or do we want to do debridement? I'm thinking we want to do debridement because we don't want anything to, infect that area more. So it's either A or B. I'm going with B because I'm going with B. Thank God. Thank you, God. I got one question right. Acute post-operative mediastinitis, rare but serious complication of cardiothoracic surgery, typically presents 1 to 2 weeks following the operation with sepsis, accompanied by signs of infection. Okay. Next question. 63-year-old man comes to the ED with substernal chest pain and diaphoresis. Pain started 1 hour ago and was not relieved with antacids. Medical problems include asthma. He uses inhaled fluticasone and peptic ulcer disease, for which he takes omeprazole. BP is 160/100. Pulse is 90. A bruit is heard over the right carotid artery, and a mild systolic murmur is present at the apex. So nitro and aspirin are administered, and within minutes, the pain is resolved. Why did the pain resolve? So let's look at this again. He has substernal chest pain and diaphoresis. A bruit is heard over the right carotid artery. So what did he have in the first place? I'm guessing some kind of left ventricular failure, just because it got better with nitro. Let's see. So alteration heart rate, no. Decreased left ventricular ejection fraction. Nitro decreases preload, right? So it could be that. Decreased left ventricular and diastolic volume. I think that's better. That's better. Increased preload, no. Increased compliance, no. Increased afterload, no. So I think it's C. Could be B, but nitro decreases preload, which should decrease the end-diastolic volume, right? Let's see. Let's find out. Okay, we got it. We got it right. Nitrates are good anti-anginal drugs. They're vasodilators. Primary anti-ischemic effect is vasodilation. Lowers preload and left ventricular end-diastolic volume, reducing wall stress and myocardial oxygen demand. Muy bien. Muy bien. Let's keep going. 43-year-old man comes to the hospital with chest pain described as dull and non-radiating. The patient has never had chest pain before, but has had occasional episodes of dyspnea and coughing in the past. Past medical history is significant for diet-controlled diabetes, allergic rhinitis, and childhood eczema. Patient's family history is significant for prostate cancer in his father and rheumatoid in the mother. Currently takes no meds, does not smoke or consume alcohol. Initial EKG shows ST depression and lateral leads, but cardiac markers are fine. Patient is admitted for further evaluation, and he's getting aspirin, clopidogrel, and heparin, metoprolol, and lisinopril. So he's being treated for, I believe it's an NSTEMI or unstable angina. He's being treated for something like that. Next morning, he has shortness of breath and a dry cough, but no chest pain. Temperature is fine, blood pressure is fine, pulse is fine, RR is fine. O2 sat is 95%. Physical exam shows prolonged expiration with bilateral wheezes, no crackles. Cardiac exam and GVD is fine. So what's causing his current respiratory symptoms? What's causing his shortness of breath and dry cough? Adverse effect of medication. I know lisinopril causes cough. I don't think it causes shortness of breath. Bronchial infection. His temperature is fine. Pericarditis. His temperature is fine. His blood pressure is fine. Pleural effusion. I don't see why a pleural effusion would happen. Pulmonary embolism. He's only been in the hospital for 1 day, so not, he hasn't been immobile for too long, and then I don't think anything else really points to that. Recurrent myocardial ischemia. Right ventricular infarction. So here's the thing, he started aspirin, clopidogrel, heparin, beta blockers, and ACE inhibitors, and then he got shortness of breath and dry cough. Why? I'm just going to say adverse effect of medication. I don't know what adverse effect, but that's what makes the most sense to me right now. Okay. And indeed, aspirin and beta blockers trigger bronchoconstriction in patients with asthma. But you might be wondering, where is the asthma? It doesn't say anything about asthma. Well, he has undiagnosed asthma, right? Because he says he has dyspnea and coughing in the past. And I guess dyspnea and coughing in the past means that he has undiagnosed asthma. So what happened is the guy had asthma. He was given aspirin. Aspirin made his asthma worse. Same with the beta blockers. That made it worse. It caused these pulmonary symptoms. Okay. So I didn't know that answer, but I got it right. So I guess that's good. That's cool. Next question. 50-year-old man comes to the office for a physical. No recent concerns and review systems is unremarkable. 5 years ago, the patient underwent mechanical valve replacement due to endocarditis. Since then, he's been taking warfarin. He's compliant. Lifelong non-smoker. All vaccinations are up to date. He's afebrile. Blood pressure's fine. Diastolic murmur at the left sternal border. Best appreciated with a breath hold. So this, it's not, and we know this because of a few questions back, it's not HCM. It's not hypertrophic cardiomyopathy because hypertrophic cardiomyopathy is not diastolic, it's systolic. So what is diastolic murmur at the left sternal border? I'm thinking aortic regurg. I'm thinking pulmonic regurg. Lungs are clear. Abdominal exam is normal. Last INR was I think that's kind of high. I don't know. I think that's kind of high. So what is the next step? CBC, echo, stress testing, hypercoagulability, routine clinical follow-up. With the INR being high, I'm thinking we should do some kind of a coagulability study. But with this weird, murmur, I'm thinking we should do an echo. I don't think we should do stress testing because we do that for angina. He doesn't have angina. CBC, I think realistically we should do a CBC, but not the best next step. But in real life, I think we would just draw a split and look at it, right? But anyways, routine clinic follow-up, maybe that's it. Maybe he's just fine. So I'm stuck with between B, D, or E. Because of this murmur, I think we should do an echo. Okay. So the murmur is aortic regurg. And then that's because the valve isn't working. And so we want to do an echo to look at that. Next question, almost halfway done. A 32-year-old woman is brought to the ED due to 12 hours of imbalance and dizziness. Everything else is normal. I think hematocrit is a bit low, right? Let's see. Hematocrit, yeah, it's low. Leukocyte count is also, I think it's on the lower side, isn't it? Let's see. But let's look at that. Okay. Yeah, it's low. So she's got pancytopenia. The platelets are also low. Neuroimaging shows an acute cerebellar infarction. Echo shows several small oscillating densities on the mitral valve with mild microregurg. Multiple sets of blood cultures are negative. What is the best next step? So she had this stroke, and then logically we would think the stroke is because of some shit on her mitral valve going up to her brain, aka, endocarditis or vegetations or some shit. Okay. But the workup was negative, right? It's not infectious, is what I mean. So maybe, and then what's going on with this pancytopenia? I have no fucking idea. Let's look at the answers. EKG monitoring. I don't know why you would do that. ANCA testing. I don't know why you would do that. Antiphospholipid antibody, maybe. Because I know SLE, I know lupus causes this pancytopenia. I know that antiphospholipid antibodies associated with lupus. I'm guessing this infarction might have something to do with like strokes or with antiphospholipid antibody syndrome can cause shit like that, is my understanding. Colon cancer screening, I don't know why you would do that. Mitral valve surgery, maybe, but is it the best next step? I don't know. So let's go with C. Okay. Okay. So endocarditis was not bacterial, and that occurs with cancer or lupus. So you want to look for either a malignant or coagulable workup. And for the coagulable workup, you want to do those antiphospholipid antibodies. Okay, good. Next question. We're past halfway done now. We'll need a couple more cookies and then keep going. Got some black tea here. Okay. 20-year-old man comes to the office after a recent shoulder dislocation. He's had multiple joint dislocations since childhood. That immediately makes me think he's got one of those weird fucking like he's got Ehlers-Danlos or Marfan or something like that. Okay, next question. I mean, let's keep going. Let's keep reading. He also notes easy bruising and poor wound healing. So he's got some fucking genetic stuff going on here. He's kind of tall, 176 centimeters. Weight is 70 kilograms. Um, so I like how this is what UWorld fucking likes to do. They love to fucking do this. Whenever there's a problem with the BMI, they don't give you the BMI. I figured that out a few days ago. So, anyways, this basically means he's skinny. His height is big and his weight is low. Um, Physical exam, he has several wide atrophic scars on the upper extremities. Okay, and then so yeah, so I was thinking, it's something genetic, right? And then I look at the options. I'm like, okay, wow, there's like fucking 5 things here. Great, great. I'm so smart. I narrowed it down, didn't I? So, anyways, is it achondroplasia? No, because that causes like dwarfism, shit like that. Ehlers-Danlos, it could be. Klinefelter, no, because you would see more stuff about like gynecomastia and fertility. What just happened? Shit, what just happened? Okay, so it's not Klinefelter. Marfan, it could be osteogenesis imperfecta. It's not that. Okay, so it's either Marfan or Ehlers-Danlos. The echocardiogram says the heart is normal. I think in Marfan, the heart is abnormal. With these joint dislocations and stuff, I'm thinking hypermobility. So I'm thinking Ehlers-Danlos right now, but it could be Marfan. It's Ehlers-Danlos. Good, 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 good. So joint hypermobility, skin hyperextensibility, tissue fragility, poor wound healing, all of that says Ehlers-Danlos. Um, Marfan, so Marfan would have excessive long bone growth and aortic root disease. Um, and I guess his height is normal and his heart is normal. So it's not Marfan. Good. Pat on the back. Let's keep going. 67 male. You know, I wouldn't be super worried about this right now if the test wasn't like 2 weeks from now. That's what's really like making me worried. But anyways, let's keep going. 67 male with hypertension uh, comes to the office. Despite escalations in therapy, his hypertension is persistent. He has headaches sometimes. Other conditions are diabetes, coronary artery disease, and ischemic stroke. Residual left-sided weakness from that stroke. He had a CABG or cabbage, or I don't know. He had a coronary artery bypass 7 years ago and an endarterectomy 5 years ago. His current regimen is lisinopril, chlorthalidone, amlodipine, and carvedilol. So there we go. Blood pressure is 184 over 120. That is concerning in it. And in the right arm, it's a bit lower, but still kind of high. Physical exam shows an upper abdominal systolic diastolic bruit. What's going on? Is it an abdominal aortic aneurysm? Is it a coarctation? Is it a dissection? Is it a enteric fistula? Is it a renal artery stenosis? The bruit makes me think it's a dissection. Why would it be a coarctation? What about this there's nothing about it that makes me think coarctation. Abdominal aortic aneurysm. I feel like that causes hypotension, not hypertension. Aortoenteric fistula. That means that like there's blood going from the aorta into your bowels. So that would have stuff about him like shitting blood and stuff, but I don't see any of that. Renal artery stenosis, it could be that, right? It could be that. That causes hypertension for sure. Causes resistant hypertension for sure. And he's got that bruit. The bruit is associated with the renal artery stenosis, is it not? But it's the bruit is in the upper abdomen. It's not on the kidneys. So with the bruit being on the upper abdomen, that makes me think. So it's either a C or D. It's either dissection or stenosis. There's nothing in here which makes me think it's not stenosis. Besides, well, there is something the bruit being in the upper abdomen. But you got to choose. I can't just waste time thinking about it, right? So is it dissection? Is it stenosis? I'm gonna go with stenosis. I feel like it's probably dissection. But let's go. Let's go. Okay. Ooh, okay. Dissection presents with tearing chest or back pain. Yeah, I was thinking maybe it's like a chronic dissection. So um, upper extremity pulse deficits are associated with dissection. Okay. So this is a renal artery stenosis. And then the abdominal bruit is associated with that. And it's highly specific for renal artery stenosis. So the bruit does not have to be on the kidneys. It could be anywhere in the abdomen, I guess. Okay, cool. Cool. So resistant hypertension should make you think renal artery stenosis. Next question. Vamos. 28-year-old woman, G1P0, 34 weeks gestation, comes to the ED with sudden onset, severe chest and epigastric pain. The pain is constant, deep, sharp. Pregnancy has not been uncomplicated except for nausea and occasional vomiting. No chronic medical conditions, no multivitamins. She takes multivitamins, no smoking, tobacco, alcohol. BP is hypotensive, pulse is bradycardic. Uh, respirations are basically normal. She's diaphoretic, she's uncomfortable. JVD, ST elevation in the inferior leads and reciprocal depression in the anterior leads, wide intermediate sternum. Okay, so she has a heart attack, right? I mean, she's got the diaphoresis, she's got the chest pain, she's got the ST elevations. ¿Por qué? Aortic intimal tear. I feel like that would be a dissection, not a heart attack. Coronary or atherosclerosis, I don't see anything that indicates that. It didn't give me her BMI, but that's okay. Deep vein thrombosis, esophageal tear, pericardial inflammation. The JVD and the hypotension make me think pericardial inflammation. But it could also just be hypotension because the heart isn't working, right? But I'm going to go with pericardial inflammation. And I got it wrong. Yay. Abrupt onset severe chest pain associated with a widened mediastinum in late pregnancy or the early postpartum period should raise concern for dissection. Type A aortic dissection can extend into the roots to cause coronary artery occlusion and myocardial infarction. And widened mediastinum should trigger those light bulbs. Widened mediastinum, aortic dissection. So what happened here is she had an aortic dissection which extended proximally to occlude the RCA, and that caused the myocardial infarction. And I should have known this. You know why I should have known this? Because this was a big thing in step one. This was actually on the free 120 for step one. Yeah. So maybe that says something about my memory, huh? But okay, okay. Question 24. A 34-year-old male comes to the ED with chest pain. It's acute. Feels like a substernal pressure. It's severe. He also feels as though his heart is racing. Makes me think palpitations, eh? Patient's medical history is significant for appendectomy a year ago. Seen in the ED 4 weeks ago for anxiety, palpitations, 6 weeks ago for chest pain that resolved spontaneously. So he has some, let's see, his father died at age 64. He has some family history here from some heart problem. And his mother died of ovarian cancer. On a physical exam, he's agitated, he's sweating. He has hypertension. His pulse is tachycardic. The respirations are 16. Pupils are dilated and reactive to light. No heart murmurs. Abdomen is soft and non-tender. EKG shows tachycardia with ST elevations in V1 through V4, so anterior lead ST elevations. What's going on? Yeah. So all of this shit about the heart racing and stuff, that makes me think substance abuse. Makes me think cocaine. With the pupils being dilated, makes me think cocaine. With the hypertension, makes me think cocaine. And then cocaine can cause stroke. It can cause aortic dissection, right? Right. Um, so that's number one diagnosis. Is it pericarditis? I don't think so. Dissection could be, dissection. Atherosclerosis, no. Pulmonary infarction, no. Stress-induced cardiomyopathy, maybe. So I'm thinking cocaine, and that's what it is. You ever heard that song? If you want to get down, down on the ground, cocaine. It's Eric Clapton. It's a good song. Okay, next question. Well, let's check why it wasn't dissection first. B. Cocaine can lead to pulmonary infarction, okay, and rarely can cause dissection. However, this patient's clinical presentation and EKG changes are consistent with acute STEMI. Fine, fine, cool. And then complications of cocaine are stroke, dissection, and MI. Cool. Next question. 18-year-old woman comes to the office for a physical prior to beginning a community college program. Recently moved into a fourth floor apartment and reports some mild dyspnea with climbing stairs. No chest pain, lightheadedness, or syncope. History of heavy menstrual bleeding for which she takes oral contraceptives. She does not use tobacco and consumes a few drinks at parties. One of her younger sisters had a heart defect. Temperature is 36. Blood pressure is 100 over 60, a bit low. Pulse is normal. Respirations are a bit on the lower side. Pulse ox is good. Weight is 75. Height is 160. BMI is 29, a bit on the higher side. Pink conjunctivi. No JVD. Lungs are clear during expiration. High pitched sound after S1 on expiration. Grade 3 out of 6. Systolic crescendo, decrescendo murmur. Loudest at the left upper sternal border. S2 is split. Okay, so split S2 immediately makes me think ASD. But because she's a bit older, maybe it's, pulmonic stenosis instead. Murmur does not increase with standing. Bursalis pedis pulses are fine. Okay, so ASD, yeah, the split S2, right? Bicuspid valve, aortic stenosis. I don't know. I don't see anything about that right now. Functional murmur. It's not, I think functional means it's normal, right? That's benign. I don't think so because she's having the dyspnea. HCM. I don't think so. Pulmonic stenosis, maybe. Tricuspid regurgitation, maybe. So I'm going to go with pulmonic stenosis because both pulmonic stenosis and aortic regurgitation murmurs both localize there to the left upper sternal border. Both have the split S2. And I think the difference is something with inspiration, like one gets better, one gets worse. And I think it said some shit about that in here, did it not? Splitting increases with inspiration. So I'm guessing, I don't know for sure, the inspiration, I think that's indicating that's pulmonic stenosis, not ASD. Let's submit. Let's see. Okay, it's pulmonary stenosis. Good, good, good. ASD is widely split without variation. Okay, so ASD actually does not change with respiration. Okay, so pulmonic stenosis, congenital defect, can remain asymptomatic until adulthood. Um, Cardiac auscultation reveals an ejection click followed by a crescendo decrescendo systolic murmur. Muy bien. Muy bien. Chocuzel. Let's keep going. Your analysis shows 1+ protein, otherwise normal. Okay. Which of the following is the likely diagnosis? Deconditioning heart failure, interstitial lung disease, nephrotic syndrome, pulmonary embolism. Okay, let's read the question. 86-year-old woman, difficulty breathing with exertion and nocturia. She's had these symptoms for 6 months. Symptoms are worsening. She has no chest pain, palpitations, or syncope. History of chronic hypertension, takes lisinopril. BP is hypertensive. JVD is present. Lungs are clear. No heart murmurs. Abdomen is mildly distended. She's got edema. BNP is high. So right now everything's saying heart failure. D-dimer is fine. Chest X-ray. Well, chest X-ray is normal, which is kind of weird for heart failure, but Oakley dokley. Your analysis shows 1+ protein. So what is it? Is it deconditioning? I don't know what the fuck that means. Is it heart failure? I think it is. I think it is, with the BNP. But, UWORLD likes to trick people, and there's a bunch of other shit going on. Is it ILD? Is it interstitial lung disease? I don't think so. Is it nephrotic syndrome? It could be. Yeah, there's protein in the P. And then nephrotic syndrome maybe is causing some of this other stuff, right? Possible. Pulmonary embolism, no. So nephrotic syndrome or heart failure is what I'm thinking. The JVD and the BNP make me think heart failure. This history of hypertension, taking lisinopril, the urinalysis makes me think nephrotic syndrome. I feel like, because I'm redoing my incorrects, I probably had this question in the past and I probably said heart failure in the past. So I'm guessing it's nephrotic syndrome. So let's see what happens. That was stupid. That was fucking stupid. So it's heart failure. It's obviously heart failure. I don't know why I got this question wrong the last time, but it's obviously heart failure. So decompensated heart failure with dyspnea on exertion, JVD, blah, blah, blah. It's not nephrotic syndrome. Yes, she has proteinuria. Yes, she has edema. Yes, she has dyspnea. But the JVD and BMP say heart failure. So, okay, next question. Two-year-old boy is brought to the ED with respiratory distress. Past 4 days, he's had rhinorrhea, nasal congestion, and low-grade fever. Today, he appears increasingly tired, has decreased urine output, and his breathing is labored. Patient has no chronic medical conditions. Temperature is 38.2, pulse is 155, respirations are 48, blood pressure is 60/40. Pulse ox shows O2 set of 91%. Scattered mobile subcentimeter lymph nodes are palpable in the anterior cervical chain bilaterally. Exam shows tachy, gallop, and holosystolic murmur at the apex. Brachial and femoral pulses are 1 plus. He has tachypnea, nasal flaring, subcostal retractions, and rales. So wow, let's look at this text. Pretty much everything is highlighted. There's a shitload of stuff going on here. And a shitload of buzzwords, which made me think of certain things. Yeah. The nasal flaring, the tachypnea, the subcostal retractions makes me think it's bronchiolitis. But then there's other stuff going on, right? There's this 3 out of 6 holosystolic murmur at the apex that makes me think of VSD. Got palpable lymph nodes. The vitals vitals are fine because it's a kid, so we can ignore the vitals. He's got fever, got urinary symptoms. So I'm thinking Kawasaki because whenever there's a kid with a bunch of fucking shit going on, it's Kawasaki. That's what I've learned. That's what I've learned after getting every single fucking Kawasaki question wrong multiple times. So I think it's Kawasaki. Is it rheumatic fever? No. I mean, that rheumatic fever, Jones, right? Joints, myocarditis, nodules, erythema, marginatum, statin hemicardia. I don't see that stuff. Could be bronchiolitis, but there's other stuff going on. It could be glomerular. No, it's not glomerulonephritis. I don't see any bloody pee. So it's Kawasaki. Myocarditis. Myocarditis would be like somebody has, could be myocarditis. Because he was sick for the past 4 days, and now he's having some like heart symptoms, right? But I'm gonna go with Kawasaki. Fucking A, man. So myocarditis can occur in the acute phase of Kawasaki. However, the diagnosis of Kawasaki requires 5 days of fever. Wow, so they're doing this fucking shit with me. So it's not enough that he has a fever. No, it has to be at least 5 days of fever. He only has 4 days. And then also needs the rash, lymphadenopathy, conjunctivitis, mucosal changes, extremity changes. So okay, it's not Kawasaki, which means it's myocarditis, which is uh, viral protum followed by respiratory illness, murmur, gallop, cardiomegaly. Okay. I just hope that I'm learning from this. You know, that I don't fucking forget this shit in the future and get this question wrong again. "32-year-old man comes to the ED with 3-day history of fever, cough, and weakness. BP is 120 over 80. Pulse is 110. Needle tracks on the arms. Sinus tachycardia. X-ray shows scattered ground lesions in the lungs bilaterally. Yeah, so the needles and the heart symptoms, the needles and the fever and stuff immediately makes me think infective endocarditis, but heart symptoms aren't that prevalent. He's got fever, he's got cough, he's got weakness, he's got tachycardia, and he's got a bunch of shit in his lungs. Maybe because he uses needles, he has HIV. And maybe because he has HIV, he has pneumocystis jirovecii. Hmm? Okay, what else would we expect to find? Diastolic murmur best heard when standing up. I mean, when sitting up. I don't know what that. I think that means aortic stenosis. I don't know. Splitting of S2, ASD, S4 when he's in the left lateral decubitous position. Systolic murmur that increases on inspiration. Systolic murmur that increases with standing up. So I know E's talking about hokum. or whatever the fuck, hypertrophic cardiomyopathy. Um, D is talking about what? I don't know. No sé, señor. C is talking about what? Some kind of stiff left wall. D, B, I don't know. So I don't fucking know. I'm gonna go with E because I know E. At least I know what E's talking about, right? Okay, so I was right about being suspicious about endocarditis. And then the most common murmur associated with endocarditis is what? It's tricuspid regurg. Tricuspid regurg is a systolic murmur that increases with inspiration. Mm-hmm. 50-year-old man comes to the office for hypertension, diagnosed with hypertension a year ago and takes a thiazide and an ACE inhibitor. Also exercises regularly and has entered into a low salt diet. Quit smoking 2 years ago. Still drinks a little bit, drinks a lot actually. Does not use recreational drugs. His dad died of a stroke at age 60. BP is higher, 143 over 88. Pulse is 76. Exam is normal. Labs are fine. What's the next step in managing hypertension? So he has a thiazide, he has an ACE inhibitor, and he's still hypertensive. So I'm guessing the last time I did this question when I got it wrong, I probably chose A. He has to stop drinking, right? But the real answer is actually B. Increase the dose of thiazide diuretic. And I just remember this. So wow. Wow. Okay, never mind. So we see the risks of hypertension here, and then alcohol is one of them. The reason I chose B, not just because I thought I remembered it, but if he's still persistently hypertensive, you would want to adjust the medications to treat that, right? That's what I was thinking. So, but it says that you don't want to titrate antihypertensive meds if he's drinking a bunch of alcohol. So we got to handle that alcohol intake first. Okay. Yay, primary care. Okay. 17-year-old boy. He's an athletic kid. Vitals are normal. BMI is on the higher side. Guessing because that's because of muscle, right? Yep, he's well built, increased skeletal muscle mass. EKG shows normal rhythm. T wave inversion leads to V5 and V6. Echo shows left ventricular hypertrophy with impaired early diastolic showing mild left atrial enlargement. It's either if it's either athlete's heart or hypertrophic cardiomyopathy. With hypertrophic cardiomyopathy, I don't think you'd see the atrial enlargement. And also, I would expect to read something else about symptoms, maybe, right? So I'm thinking athlete's heart. And of course, I had it backwards. I had it backwards with athlete's hearts. You see normal left atrial size and slightly increased cavity size of the left ventricle. So this is cardiomyopathy because of the dilated atrium and the dilated ventricle. Okay, next question. 52-year-old woman was brought to the office, brought to the ED because of unresponsiveness. She recalls rushing to catch a bus for work, began feeling sweaty and warm after sitting down, lost consciousness and then slumped in her seat, regained consciousness after approximately 1 minute, was not confused afterwards, never had a similar episode and reports no chest pain or palpitations prior to the event. Medical history includes hypertension in children. Medications are amlodipine and artificial tears. Has MI in the family. Regularly walks 2 blocks. Good for her. Okay, good. Mild orthostatic hypertension. Mild, not relevant in my opinion. Everything else is normal. Okay, what do we do next? So basically, she had an episode of syncope, right? She began feeling sweaty and warm, so she had this prodrome, and then she lost consciousness, sunk in her seat, and then she regained consciousness, and then there was no post-ictal like confusion. So what this is vasovagal syncope with the prodrome and then the passing out. So what do we do for that? Do we want Holter monitoring? No. CT scan? No. Echo? No. EEG? No. I'm thinking we want nothing. Nada. Good. Good. 42-year-old woman comes to the ED due to increasing dyspnea and lower extremity edema. No chest pain, palpitations, or syncope. History of heart failure with reduced ejection fraction due to pericardial cardiomyopathy. Okay, so he's got HFrEF. Left ventricular ejection fraction was 30% 2 months ago, which is low. Exam shows elevated JVP, bibasilar crackles, and bilateral edema. She's got heart failure on both sides. Both sides are fucked up. Okay, so she's admitted. They give her furosemide, Lasix, and then they send her home. I mean, they start her on her home meds for all the heart issues she has. Day 3 of hospitalization, the rhythm shows this. I think this is like a monomorphic ventricular beat or some shit like that. So, lasted for several seconds before spontaneously reverting back to normal. Physical exam, lung crackles and edema have improved. What's the next step? I think she's fine. But let's see. Antiarrhythmic, no. Anticoagulation, no. She's not an AFib. Let's measure electrolytes. I don't think so. D, she's fine. Está bien. That's what I think the answer is. Fuck. The fact, what pisses me off, is that this is my third time doing these questions. The first time was last year during clinical rotations. Then I did them again a few months ago. Now I'm redoing my incorrects and fucking getting these wrong again. It's frustrating. All right. So non-sustained, and I even have Anki cards. So the Anki cards aren't helping either, because I know I made an Anki card about this exact same fucking rhythm. Okay. So when somebody has monomorphic non-sustained ventricular tachycardia, what you want to do is address the precipitating factors, which are electrolytes, or consider beta blockade. '68-year-old man, chest pain, hospitalized 2 weeks ago with chest pain, was diagnosed with an stent. PCI was performed, further with the stent was placed. He's taking all his meds, he's on aspirin, clopidogrel, and has limited physical activity to prevent overexerting the heart. He's been feeling well until last night when he began having sharp left-sided chest pain, which worsened with deep inspiration. Yeah, so I'm thinking pericarditis right now. Blah, blah, blah. Other medical conditions are hypertension, hyperlipidemia. He smokes. He quit smoking 2 weeks ago, I guess. He has fever. Again, I'm thinking pericarditis. O2 size 92%. BMI is on the higher side. Mild or extremity edema. EKG is normal to some tachycardia. Troponin is a bit high. Everything else is fine. What's next? Do we do a CTA? For what? To look for pulmonary embolism? I don't think so. His vitals are basically normal. Emergency angiography. Ibuprofen and colchicine for the pericarditis. Myocardial perfusion. Serial EKGs. With the troponin being high, you know, with the troponin being high, I feel like we should do something about that. Even if we think this is a pericarditis, I think we should do something about that. So I'm going to go with the serial EKGs. But I wouldn't be surprised if the answer was C. But let's see what happens, huh? No, the answer is A. No, the answer is fucking A. Apparently, it's a pulmonary embolism. So, dyspnea, tachycardia, tachypnea. What tachypnea? Why the fuck are his respirations 20 if he has tachypnea? Anyways, apparently he has tachypnea, dyspnea, tachycardia, and unilateral lower. Oh, you fucking. He has unilateral edema. That should have immediately. That's PE. The edema on one side, that means he has a DVT in that leg, and that went up and that went to the heart and the lungs. So yeah, that should have been fucking obvious. So it doesn't say anything about the troponin being high, and then it doesn't say anything about pericarditis. But yeah, he's immobilized. He has the fucking right lower extremity edema. Was not that hard a question. 67-year-old man comes to the ED after losing consciousness while shoveling snow near his house. Similar episode a month ago while carrying heavy bags. Reduces physical activity due to progressive exertional dyspnea and fatigue. Other problems are diabetes and hypercholesterolemia. Does not smoke. So I'm thinking aortic stenosis, with this exertional dyspnea. So what do we expect to see? Pulsus parvus et tardus, right? Which means weak and slow rising cardiac pulse. Okay. All right. 6 more questions, okay? We can do it. Podemos hacerlo. 56-year-old man comes to the office for progressively worsening fatigue, difficulty concentrating, and increasing forgetfulness acutely. In addition, he's had vague abdominal pain and constipation. He's gained 2.7 kilograms unintentionally over the last 3 months. Medical history is significant for hypertension, non-ischemic cardiomyopathy, and AFib. BP is 140/90, pulse is 75. Physical exam shows normal heart sounds. Lungs are clear to auscultation. No lower extremity edema, and the skin appears dry. Lab studies are below. Okay, sodium's fine, potassium's fine, chloride's fine, B1 is a bit high, creatinine is a bit high. I mean, they're basically normal. Glucose is fine. ALP, I think, is normal. Let's just double check here. Yeah. Oh, ALP is a bit high. And then AST and ALT are mildly elevated. Okay, so which medication is causing his symptoms, huh? I think it's digoxin. Could be amiodarone as well, because both of those medications do. They have some fucking side effects. Dofetilide, I don't know. Hydralazine, no. Metoprolol, verapamil. The elevated liver enzymes. I think digoxin causes like digestive symptoms, though, like it causes diarrhea and stuff like that, which he doesn't have. So I'm thinking amiodarone. Gotta fucking go with amiodarone. Let's see what happens. Thank God. I got it right. So amiodarone causes hypothyroidism, or it causes a bunch of thyroid issues, and then I guess that's what's causing his, problems here. And then it also causes the hepatocellular injury, which elevated his liver enzymes. Good. Next question. Okay, this EKG, I'm looking at it. I see the PQRST is fine in all the leads. The RR intervals are normal. I don't see any electrical alternans. It's looking grossly normal to me. Okay, let's read the question. He comes to the hospital because of chest pain, substernal, 6 out of 10, pressure in his chest, hypertensive, uncomfortable. Biomarkers are pending. Aspirin and nitro are administered. Patient is reevaluated 20 minutes and still has chest pain. What's the next best step? All right, so I want to see what his troponin is because I think his EKG is normal, but what if his troponin is high? I don't know. It doesn't say in the question step. What it does say is we can admit him to the telemetry unit and repeat. So that means continuous EKG and repeat the biomarker testing for hours. That's what I'm inclined to do, right? But what about CT scan of the chest without contrast? He's got this, he doesn't have any EKG changes, but he has this constant chest pain, what he says is the pressure-like sensation. What if there's something in the track over there? Repeat the EKG in ED. More. Uh, yeah. So right now, I think it's right. I don't think it's but the chest pain is persistent. Instead of slow. But he's not acute. is like so fucking frustrating. So fucking frustrating. Okay. He's got acute coronary syndrome. That much we figured out. Initial EKG was normal. I guess that's normal for the initial EKG to be normal, and you have to repeat the EKG. And then if the EKG shows ST segment elevation, that's when you do the stenting. Cool. 4 more questions. 63 male has left leg pain. Typically has pain in both legs after walking a couple of blocks, but several hours ago. Severe left leg pain suddenly developed while he was resting. Reports numbness in left leg and also experiencing intermittent palpitations. He used to smoke a lot. Pulse is 116 and normal. Hair is sparse. Okay, so I'm thinking this is some kind of an arterial occlusion. Distal pulses are absent on the left. Sensation is decreased. We want to anticoagulate him, and then we want to do surgery. We'll heparin. Thank you, God. As soon as acute limb ischemia is clinically diagnosed, anticoagulation should be initiated. Okay. But I was also wondering about this. The surgical bypass grafting is typically used in the setting of chronic PAD. Yeah. So that's not even the, okay. Cool. Next question. A 73-year-old woman comes to the office for preoperative evaluation prior to arthroscopic rotator cuff repair under anesthesia. Does not routinely exercise, but keeps a large garden and does her own laundry in the basement. Has no chest pain, palpitations, dyspnea, lightheadedness, or orthopnea. Medical history is notable for an ST segment elevation, myocardial infarction requiring stent placement to her RCA 3 years ago. Other medical conditions include diabetes, hypertension, dyslipidemia, takes oral meds, does not use insulin. BP is 140/86, pulse is 76. Jugular veins are not distended. No pedal edema, creatinine is a bit high, EKG is fine, even though she had that ST elevation past. Okay, so what's the preoperative management here? I think she's fine. Patients undergoing non-cardiac surgery should be assessed for perioperative cardiac risk based on procedure and patient-specific risk factors. Low-risk patients and those at increased risk with adequate functional capacity can typically undergo surgery without further testing. So she's low risk and her functional capacity is fine. So her only risk was the heart disease. Everything else. She's also got diabetes, right? But it's not treated with insulin. Okay. Okay. Dos más. 13-year-old girl. from Southeast Asia. Medical history includes a febrile illness a year ago. That was followed by pain and swelling in her knees. So a year ago, she had a rheumatic fever, right? At that time, they gave her NSAIDs and the symptoms resolved. Or maybe not, maybe it was something else. Last physical exam 2 years ago was prior to her immigration. It's fine. She plays soccer, she swims, blood pressure's fine, BP's fine. Diminished F1, 2 out of 6 holosystolic murmur at the apex, which radiates to the left axilla. Either that's mitral regurg. I think it's mitral regurg. I don't think it's VSD. Yeah, there we go. Good job. So what is the most appropriate treatment? She's not symptomatic, so I don't think anything's indicated. Methotrexate will be for like some kind of it'll be for like rheumatoid arthritis. I don't know what else you'd give it for. Beta blocker. Why is her S1 diminished? I don't know. Penicillin, with the history of rheumatic fever, I don't know. I don't know. I don't know if penicillin is something you just give during the fever or if you always have it. So that's something maybe warfarin. So it's either penicillin or it's nothing. I think it's nothing. So you're supposed to give penicillin until the age of 21 every 4 weeks with rheumatic fever. Next question. 75-year-old man, heart murmur. No symptoms, has some hypertension, which he takes chlorthalidone and amlodipine for. He's a smoker. Single soft S2 and an S4. 3 out of 6 systolic murmur heard at the right second intercostal space, right here. What is heard at the right second intercostal space systolically? Aortic stenosis with radiation to the right carotid artery. Okay, it's aortic stenosis. Carotid pulses are delayed. Aortic stenosis. TTE shows a thickened left ventricular wall. EF is 45. Tri-leaflet aortic valve with, you see, the thing about UWORLD is, I knew it was aortic stenosis, but it's not going to ask me if it's aortic stenosis. It's going to fucking ask me something else. No, that would be too easy, right? So tri-leaflet aortic valve with heavy calcification, valve area. Valve area is pretty low, pretty small. So severe aortic stenosis, what's the next? So he needs a valve replacement, is what I'm thinking. Yeah, see. Because yeah, the valve area less than 1. Yeah, he needs a valve replacement. All right. Let's see how we did. 52%. So, the fact that I'd done all these questions before and only get 52% when I do them again, it's kind of annoying. But fine, I'll take it. So the surgery stuff I remembered pretty well. The medicine stuff, not so much. The peds stuff, definitely not. Okay. All right. So, okay. With that, thank you guys for watching. I hope this video is of some benefit to you. And it was definitely helpful for me to actually talk about these questions. And you know, put my thoughts out loud. So, anyways, it's a long video already. So, um, yeah, thanks for watching and good luck to both of us.